Carol basically has, I guess, had experiences that would appeal to virtually everybody in this audience. She's been an undergraduate, graduate student, postdoc, university professor type. She then found her way into NIH, where she literally, I think, manhandled or started their programs on technology and biotechnology development. She went to an organisation that was called Biospec that I Googled, and it wasn't on my Google, but never mind. Anyway, very famous organisation. But then she found her way to the Bill and Melinda Gates Foundation, and it's where I first got to know Carol. She was, I guess, the person responsible for the Grand Challenges in Global Health program, which is an extraordinarily innovative, bold program by the Gates Foundation, one of the largest of its type, I think, anywhere, and one of the most ambitious of its type. And Carol was, for the 400 or so researchers involved in this program, very much the face of the Gates Foundation for this program. So because she did such a great job, she got kicked upstairs. She's now the director of staff for the Global Health Program, but more importantly, she also, I think, is the deputy to the president of the whole global health system at the Gates Foundation, and I'm sure she offers advice from her many, many different useful perspectives. So thank you very much for coming, Carol.
Your comment about not finding Biospec is a lesson in what happens with biotech companies. They either go under, or in that case, 2 name changes later, they exist in a new form. Let me see here. Let's get up to slides. Here we go. Great. Well, I want to thank you for inviting me and the opportunity to come up and speak with our neighbors here in Vancouver. I was lucky. The border was only about 20 minutes today, so I watched the signs as I got closer and thought, oh my God, did I leave enough time? But I did. So very pleased to be here today. You've got the same weather we've got in Seattle today. So I want to take the time today to actually maybe lift up a bit. We had a wonderful and compelling story about a really devastating disease in India and some other countries as well. And the story of passion that I think came from the last speaker about how much work, how much dedication, and how much challenge it takes to deal with one such disease and try to make a change in things moving forward. We're going to step up a bit and maybe elevate it to across a variety of diseases and talk to you about the work we have ongoing at the Bill and Melinda Gates Foundation as a window into global health, the problems in global health, but also the opportunities to make a difference. And so I'd like to start by weaving into it a little bit about the foundation. It's not surprisingly, when I go talk to people, usually they aren't too familiar with the foundation, or they think they are, and then they find out actually they don't know that much about us. So I'd like to take a few minutes to tell you about the foundation itself, and then tell you a little bit about how we set our priorities and how we think about global health and why we're actually interested in global health. And then I want to take you down a path of telling you about what we think are some of the key things that need to happen in terms of making a path towards impact against the devastating diseases that affect the poorest populations in the world. And ultimately, I want to end with sort of a challenge to you to get involved and the opportunities that there are to actually take part in the solutions. So just to get started, I'm from the Bill and Melinda Gates Foundation, and I do represent the President's Office in the Global Health Program. So the foundation itself actually got off the ground in about the year 2000. I'll give you a little bit on the history in just a minute. But we really focus on one single premise, and that is the belief that all lives, no matter where they are lived, have equal value. And so this is a recurring theme throughout the work we do, and I'll tell you just a little bit about the range of work that we are engaged in. But it actually is the filtering mechanism for us in terms of when we get engaged and when we actually put the dollars of our co-chairs, Bill and Melinda Gates and Warren Buffett, against the problems that we seek to address. Our approach, not surprisingly, given who our founders are, is based around the belief that science and technology can make a difference. If you look across the problem sets we're working in, you'll see a common theme that there is the opportunity for science and technology to actually transform the way you create a solution and actually accelerate the way to making an impact on what is the inequity that we're hoping to address. So a bit about our history. It really starts back in the 1990s. Bill and Melinda had thought that they would get engaged in giving back to the world, which was always their commitment and very much driven by their own personal philosophies and the philosophies of the families that they happened to grow up in, that they would give back what they felt to be, in some sense, the opportunity they were given, largely because of the birth lottery of where they were born, the opportunities they had, and the ability to take their passions towards something that ended up being enormously lucrative. But there always was a commitment there, but they didn't think they would get involved until later in life when they had kind of stepped away from their careers and so on. But it was actually a World Health Report that came out in the 1990s that changed their minds. They had read some articles in the paper about rotavirus. Rotavirus is a devastating disease that actually causes diarrhea across the world. But here in North America and in developed countries, actually, it doesn't actually result in death. Children are treated and actually continue to live. They were really stunned when they found out that millions of children die each year from diarrhea across the world. And it was a hidden disease that people just weren't taking a look at and doing something about, which led them to reading the World Health statistics and getting involved in realizing that there was an enormous inequity out there that really needed to be addressed. So in a sense, global health was the first thing that drew Bill and Melinda into giving at an earlier stage than they had originally intended to do. So in year 2000, they created the foundation. They actually brought together another giving program that they had ongoing, which was around creating access to digital information in the United States through the U.S. public library system, together with their passion for global health, which they had been doing out of their sort of personal resources through their father, through Bill's father, Bill Gates Sr., and the foundation was launched. And at that time, a real focus around those two thrust areas, global health and then also the closure and completion of the U.S. Digital Information Access. In 2006, we had an enormous sort of transition in the history of the foundation. And that was that Warren Buffett, obviously one of the richest men on earth, decided that he was going to also give back his life's earnings, and that he was choosing to do it actually through his friends, Bill and Melinda Gates, through the foundation. And so the bulk of his resources will also be moving in through the foundation. And so that was a pivotal point for us to revisit our structure, revisit the way we work, and actually realize that we had a much enhanced capacity to make a difference in the challenge we've chosen to address. And then in 2008, another big transition for the foundation worth noting, which was that Bill stepped away from his day job at Microsoft, still remains the chairman there, but actually devotes his time full-time to the foundation and a few other interests he has on the side, but is really now a day-to-day participant in the workings of the foundation, which Melinda had increasingly been over the years of the foundation. So they are two full-time participants in our work and our decision-making, and very much in the view of what they would like to do and accomplish with the funds. So let me tell you a little bit about our areas of focus. As I said, we view through the filter of inequity, and we work in three major areas. Longest-standing program we have comes out of this Digital Information Project. It's the United States program. The U.S. program actually is focused entirely on education in the United States. We have some gaps that we hope to fill and create some paths for the U.S. to make a transition in the way we do, particularly secondary education and college-ready preparation. We also have a program in global development, which is relatively new. That just began in the last few years. I mention it because it has some overlaps with our interest in help, or synergies, not really overlaps. And that is, they focus on three major areas at the moment. The biggest is actually in agriculture, looking at how to actually empower smallholder farmers to improve their outputs as a way of creating sustainable economic development. That tends to be the first step in a path to sustainable economy in countries. The second area they work in is in financial services for the poor, and there builds on the kind of conceptual work that was done by Eunice and others to actually enable poor individuals to actually have ways of handling their finances and having access to finances. And then the third area, which is a new area for us, is actually focusing on sanitation, the issue that many to most of the people in the world do not have access to adequate sanitation, and that actually has a huge impact on our health goals. Finally, the Global Health Program, which is the largest program at the Foundation, and I'll speak about that in a bit more detail in a moment. So in 2009, we haven't finished 2010 yet, we paid out a total of almost $3 billion in grants, US dollars in grants, and that was, as you see, focused in these three broad areas of global development, US programs, and global health. Global health tends to be about 60% of the giving in the program. Where we are today, we actually are primarily in Seattle, so if you want to take a short drive over the border, you can come see us. But we are primarily based in Seattle. We do have some other employees distributed across the world. We have a small group in Washington, D.C., who help us with some of our policy and advocacy issues, primarily around government relations. We have a group, the newest group for us is actually just launched in London this spring, in June, very small group that focuses on relations with the European continent, and also easier access to some of the other continents like Africa and some parts of Asia. We have had for a while a group in Delhi which really grew out of a project we had in India around HIV prevention, which was called Avahan. It has now expanded its scope to doing some more work. Actually, we're beginning some integrated work in Bihar and other areas in India, so taking a more integrated focus in our projects in India. And then in China, we have a relatively new office. I think we are the only nonprofit organization that is not tied to the government in China, a private foundation in China that is actually registered there. And we are working with the Chinese government around HIV prevention and also some new programs in tuberculosis. So global health, let me turn to that. So how do we think about our role in global health? Our focus really is tied up in these few words here, which is, if you want to remember one thing about us in global health, it really is about technology-based health solutions delivered for impact. And don't forget the second half of that, because that's critical to the way we think about ourselves. So what's the context here? We heard a bit in the last talk. You've heard a bit this morning. I'm sorry that I missed the first talks. But the bottom line is that, 2/3 of the world's 6 billion people actually live in the developing world, and of the world's population, 1 in 6 live on less than $1 a day. So that's a huge factor in terms of people's ability to access health. As we heard in the previous talk, medicines are not necessarily at a different price in those countries because there are certain prices that are arrived at based on the cost of research and the cost and availability. In some cases, as the one that was articulated here, there are opportunities to work with companies and others to actually drive down the cost to get a very generous opportunity for prices. But in fact, some of the things we take for granted here, going to the hospital, things having access to imaging and other kinds of high technology, simply don't happen for most of the world's population because of the ability to pay. Millions die unnecessarily each year from diseases. So, in fact, if you take 3 major killers, particularly in adults, AIDS, TB, and malaria, kill 6 million people annually, and 99% of that's in the developing world. And we don't think about these diseases too much around here because they primarily are affecting people in the poorest populations. Similarly, 99% of the infant deaths that happen each year occur in developing countries. Actually, 4 million children die in the first 30 days of life in the world, and the bulk of those are in the developing countries. That's the equivalent, I tell U.S. populations, that's the equivalent of if every child that was born in the United States next year died. I can tell you people would stand up and there would be action. But in fact, that first 30 days of life has gone as sort of a hidden factor that has not been adequately addressed. 99% of pregnancy-related deaths are in women in the developing world. So when you get pregnant and you're in a very poor population in the developing world, the question is, will you survive pregnancy? Let alone will you have a healthy child at the end? So these are problems that need to be addressed and need to be dealt with. For some of these problems, we actually have solutions that work in our world, but don't translate well to the developing world, to the poorest and most resource-poor populations that require too much infrastructure, they cost too much, they simply don't work for the social and cultural aspects of people's lives in those settings. Or, in fact, there are cases where we just simply don't have solutions, and examples on this slide, in fact, include things like HIV and TB and malaria, where we don't have effective vaccines. And so, in fact, how do we actually create preventative solutions for those diseases? We don't actually have anything in hand at the moment. But with that kind of depressing note as a starting point, I'd say we actually are very optimistic. The bottom line is we do believe that there can be solutions, and there's been amazing change that has happened in the last generation, even in the last decade or two, in terms of the dynamics of global health and what's going on. So a few things to focus on. So, for instance, polio, devastating disease in the 50s and 60s. The anticipation was that hospitals were going to have to scale up and scale up and scale up with artificial respiratory facilities. So, in fact, putting people on heart-lung type chambers would just be scaled and scaled and scaled as polio became a problem. But in fact, it was science and technology and the innovation in vaccines and the creation of an effective vaccine for polio has actually transformed that. So in the past 20 years, we've actually eliminated 99% of the polio in the world. It's actually on the verge of being able to eradicate this disease, and that's a major focus for us at the Foundation. And we believe it's one that the world actually has to step to the plate on, because if we give up, even for a moment, it's going to creep back and it's going to continue to be a problem. The number of people receiving treatment for HIV infection has increased tenfold in just 5 years due to important programs like the Global Fund and the President's initiative out of the United States, and the generosity of countries worldwide in helping to procure HIV treatments and actually get them out there in the field. With that said, the rise of people infected with HIV means that there's no way the world can actually afford to treat everyone who will have HIV over the course of the next decade, and so we need to find better solutions. Measles deaths in Africa have been reduced by 91% in just the last decade. A 15-cent vaccine actually has made transformative change in the world, and even in some of the hardest places to reach in Africa. So huge progress there. Millions of people have been saved in malaria through cheap, affordable solutions that also require innovations. One of the biggest innovations in malaria has actually been insecticide-treated bed nets that actually have longevity and can work for 5 to 10 years and provide reliable protection while you're sleeping from insects biting, and particularly malaria transmission, because they're night biters. The other thing that you see here on this curve is a really impressive statistic that for children under the age of 5, actually the global mortality has declined more than half in 50 years, and we think that it could drop again in half by 2025 with the interventions that we have available today, and actually reaching kids and adults with those interventions. So there's a real opportunity, and as you look at what's on this list, you can see that it basically is empowering through science and technology and then delivering those new solutions that has made the impact that we've seen today. So science and technology can make a difference. So how do we think about it in the Gates program in terms of what the priorities are there? As I told you, we use the filters of inequity. So where is there inadequate attention? Where is there more burden? And where do we need to step in to actually be a catalyst where others are not choosing to go? So we focus on two broad areas. Infectious diseases, we've heard a bit about that already this morning and just this afternoon. So for us, they include the biggest killers in kids, and that is diarrheas and pneumonias, and also malaria. And then also the biggest killers in adults, which is TB, HIV, and then also, to some extent, malaria. And we also do work on some of the neglected tropical diseases as well, because they truly are without attention. We also work in family health. You heard some of the statistics before about newborns, and so the first 30 days of life, and also about pregnancy and the incredible impact. And one of the things we know there is that actually having a delayed first birth for young women, and also having better birth spacing, so a choice of actually having birth spacing, actually has a huge difference in terms of the impact on health on both the mother and also on the child. And so the opportunity to make a decision about family planning is one that we also try to support. Our number one goal is actually prevention, and as far as we can see at the moment, the number one tool that is cost effective and actually has a huge impact on prevention is vaccines. So for us, our number one goal at the moment is actually around creating and delivering vaccines. But as I'll tell you in a moment, it's not all we do. We work on a variety of things, and we think there's lots of room and opportunity to have impact through other interventions as well. As we think about our own opportunities to work in this space, and maybe something I'd challenge you to think about yourself as well as you choose what you work on for the future, is we actually hold ourselves accountable around our ability to contribute to health impact. So the measures against which we hold ourselves are really around, has the numeric out in the world change in terms of the burden of that disease and the impact it's having on the lives of children, mothers, and adults. And so we work backwards from that and say, what is it that takes to deliver impact? Well, first of all, we want to get the existing tools that are out there. So how do we reach those people who currently aren't being reached? In some cases, we don't have tools. As I said, we don't have vaccines for HIV, TB, malaria. We don't have great drugs. And as you already heard in the last, having one drug's never enough. That just means you're on a treadmill. You're going to be making new drugs forever, because resistance is really a problem that's emerging continually. So we do believe that there's room for development for new tools. And then in many cases, actually, we step back into the discovery space because we think that there are different ways of approaching the problem. We need a pipeline of things to bring into development, and that not enough innovation has actually been applied to how to address these problems in a way that will work for the populations we're talking about in the resource-poor settings. So one of the things we think about as we do our work, and I challenge you to think about as well, is that we hold ourselves accountable for the idea that anything we invest in needs to also take into account, will it ultimately be able to reach the people in those settings? Because if it can't reach people, it really won't have an impact. The second thing is we ask our partners to do that as well. So everyone who's worked with us has found out about what we call a global access strategy, which is asking the question of, as you actually handle your projects, think about how you're going to get them out there to the population and make sure that you handle your intellectual property and your other partnerships in a way that will ensure the greatest likelihood of them getting out there, which doesn't mean you don't capture intellectual property, but means that you think about how you're going to make sure that it can get access to the poor, because sometimes it's important to actually ensure it gets developed. So another comment just about how we think about things, challenge you again in your own thinking, which is we start by developing a strategy. What is it that needs to be done all the way from delivery backwards, and say what's the critical path to actually having that health impact? And then we step back and we make grants, contracts, other ways we do work against that. And then we measure progress. So we ask our partners to be accountable for progress as well, to help us think about what we learn. It's a way of actually adjusting focus and direction to ensure that we can actually get to our goals. And so we want thought partners in that as a way of moving forward. As I said, we do our work through others. We don't actually have any labs. We don't actually have people on the ground out there delivering things. And so we work through grants, contracts, program-related investments, which is some alternative financial tools, convening. We often find ourselves not investing, but actually helping to bring people together to take on tough policy problems or to stimulate a new field. And we also work in advocacy, because even though we have a fair amount of money by most standards, we don't have nearly enough to make a difference here. And it takes both political will, policy changes, and additional resources to actually ensure that these problems get tackled. So just a little window into our world. This shows you the ramp up of funding that has happened at the Gates Foundation since the year 2000. Things that were given before that were through the family themselves. And as I said, in global health, we're at about close to $2 billion this year. We will maintain the levels you see here from 2009 in the current year. And this gives you a window into our priorities. I spoke about our strategies and priorities clustering into two broad areas, family health and infectious diseases. And you can see that it is largely distributed across those things with some deeper investments in HIV, given the magnitude of the problem, and vaccine delivery, given the opportunity there and the potential for impact. I would just comment, if you want to learn more about any of the individual strategies and also how we think about our role in it, I would comment that we step back when we do strategic thinking and we kind of say, what does it take to get impact? And then we say, well, that's the world's issues. And then we step back and say, well, what's our role in that? Because there's some things we really aren't responsible for, governments are responsible for, other agencies are doing with great success, people who invest in basic research like the NIH or your own Canadian Institutes of Health Research or the Wellcome Trust. We don't want to step on their boundaries. We are thrilled with them doing the work they're doing. And so on these strategies, which you can find online as it shows up there, you can learn more about both the problem sets and also how we think about the path to solution. So just to give you a window into how we think about things a little bit, I'm just going to highlight 3 strategic areas, and then I'm going to tell you a little bit about partnerships and how we work with others. So this is an example. This is our TB strategy. We kind of create these goals for ourselves, and we focus on those. And this looks rather similar, I think, to what you'd see in terms of general categories to how we think about most of the infectious diseases, which is vaccines, as I told you, is a primary opportunity. We see prevention as the ultimate goal. But in the meantime, we also see that there is room for improvement in terms of drugs. And some of the diseases like TB, you might even argue that having more effective drugs that could treat TB in a shorter time frame could have a huge differential in terms of the transmission rate and the transmission as a whole, and actually drive down the incidence of TB in a way that a vaccine would in some sense. So for each disease, it's a bit different. Diagnostics, critically important, we find in most of the diseases. In TB, we've actually supported studies that have shown that having an improved point-of-care diagnostic is probably one of the most powerful health interventions you could actually do. If we could actually identify people with TB earlier, and 2/3 of the world's population actually is infected with latent TB. We can't find that. But even active TB, if we could pick that up earlier and actually effectively treat them, we could limit transmission in a way that would drive down the prevalence of the disease. Innovation in TB control, clearly if we don't actually take these things to action and do demonstration projects that allow other people to make policy changes and scale, nothing will ever happen in terms of health impact. And then finally, advocacy, we think about, as I said, how to mobilize resources, get political will for the changes that are needed and policies that need to change in order to affect impact in the long run. Here I highlight maternal and child health, a very different problem set. Here we know what many of the problems are. We have kind of a schism in terms of what the problem set is. We have solutions. Many of them don't work well in the resource-poor settings we're talking about, so we need to improve the technologies, and we need to actually see and find a way to get them into resource-poor settings where there aren't health facilities available. The other problem is there are actually some of the biological problems we don't understand. We don't actually understand premature birth very well. So premature birth is a challenge, particularly in the developing world, probably related to concurrent infections, state of nutrition, original health state of the mother, etc. But we need to understand that better in order to intervene and not bring in high-cost type interventions that we do here in the U.S., but actually think about more biologically oriented interventions that might help us for the long run. And then we have some cross-cutting areas. For instance, in discovery, we do a lot of work in discovery to support all of the strategies I spoke about, creating new technologies, filling gaps in knowledge. But we also think about some cross-cutting things, like if we actually had point-of-care diagnostics platforms that could be used by relatively unskilled workers in rural health communities, we could make a big difference in terms of the ability to make sure that people get the right treatment, the right interventions, and actually that we have an effect in terms of those poorest populations who may not have access to facility-based solutions. And so here you see that while we work across all of the priorities that you see on the left-hand side, we identify the solution gaps. We look at where others are already working in that space, and then we fill in the gaps around knowledge, platform technologies, and also seeding innovation, which I'll return to in a minute, to create leads. So we're always pointed on that trajectory towards impact, and we think that's important for all of us to do as a partnership, a global partnership in working on global health. So as I said, our way of doing our work is basically working through partners and partnerships. We have some representatives from those partnerships in the room, including this hosting university, as well as our partners from DNDI and academic institutions across the world. And so this is very important to us. So individual investigators make up a major pool of what we do, particularly in discovery and development work. Public-private partnerships are absolutely critical to our work in development and also in delivery. Actually, we get countering views in terms of what we do and where we put the balance of our resources, but some of our biggest investments are actually in partnerships around delivery. And we also work in global collaborations where we work with other not with other countries, but with countries, with other donors or research investors like ourselves to actually partner in terms of creating solutions. You see some of the names of those partners on this slide, as well as coordinating with other funders to accelerate things moving forward, finding synergies. And sometimes the most unlikely other funders are good partners in terms of accelerating progress. So if I take as an example here, just on this, you'll see Gavi listed as one of these. It's a Global Alliance for Vaccines and Immunization. If I work backward from that slide I show you about how we achieve health impact, we worry about delivery, development, discovery, policy, and advocacy. Gavi's been an incredibly important partner to us. It's one of the first investments the foundation did. Actually, in 2000, year 2000, it was funded as a public-private partnership. And it's a collaboration across the types of organizations that include developing countries themselves who want to be the recipients of vaccines, developed countries that want to be donors and enable the developing countries to receive vaccines, vaccine manufacturers, both in the developed world, so large multinational corporations like GSK and Novartis and so on, as well as developing world companies that are coming up that are actually creating some amazingly cost-effective solutions in vaccines. And then the non-governmental organizations who are actually critical players in helping to deliver and ensure uptake in the population. So our initial infusion was $750 million. We continue to make very generous investments each year in Gavi, but it now has 17 donors from across the world who contribute to this. It was originally hosted by UNICEF, but now is an independent foundation and has raised $6 billion to date. So what has Gavi done? Well, over the course of the time Gavi's been in existence, the financing that is provided from donor countries and through this consolidated way of actually ensuring those who need vaccines can gain access to funds to get vaccines. 257 million children have been immunized, and it's estimated that 5.4 million future deaths have been averted because of those immunizations. So that's a huge return on investment for what has happened there. About $4 billion in funding has gone to country-led initiatives, and that new vaccines have been introduced in over 70 countries. And so new delivery systems have been energized and reaching children, and 79% of the kids in the poorest countries, but still a huge gap to go. And is there room for improvement? Of course. As these organizations form and learn, there's room for improvement in how they do business. But it's evidence that, in fact, that in a collaboration like this, we can make a huge impact to make sure that the products of science and technology innovation can actually reach the poorest populations out in the field. So if you step backward to development, we have some critical partners we work with in development. Some of our people in the room are actually on this slide as well. DNDI is listed there. So we partner with others, and this is actually a broad range of product development partnerships, some of whom are our partners and beyond, who are actually working in the space of development. And it's really critical in the sense that in product development for these diseases, there's not a huge market driver. So the things that would drive a company to create a cancer a drug or an intervention for cardiovascular disease or even, frankly, for Viagra is the economic return that lays at the end of the line. And in fact, for most of these diseases, there isn't a good case study that's been made for economic return. In some cases, there is a good economic return, but they simply haven't done the work to do it because it's not a predominant developed world opportunity. But in some cases, there simply isn't. And so there needs to be a collective or a collaborative like Gavi or some other form of financing mechanism to get it out there to drive down the costs. But what happens is the companies actually need partners who understand these diseases, partners who understand the complex set of regulatory issues that go forward, and partners who understand the path to delivery for these problem sets. And so these partners are critical, and we invest heavily in them in the development space. And they're also potential partners for yourselves in the sense that they are the people you can go to when you think you might have a potential solution, where you think you might have a candidate for a drug or a candidate for a vaccine, etc. They're great partners with an incredible depth of knowledge about these particular diseases and how, in fact, to take it to a product and get it out the door. And then I turned to discovery. So stepping backwards again, I got a nice plug for the Grand Challenges in Global Health. Thank you very much for that. And I wanted to highlight here a little bit about this model. It's not the only way we invest in discovery, but it's one that provides a particularly open door. And so for people who maybe haven't been engaged with us before and may be looking for an opportunity to work with us, I think it's kind of a lesson into how we think about things, and also highlights what we feel to be some of the greatest challenges left in terms of discovering new solutions, using science and technology to discover new solutions. So back in 2003, Bill Gates asked the question of the then-time president of the Global Health Program at the Gates Foundation, it was Rick Klausner. He said, why don't more people work on global health? I mean, the bulk of the world's problems are basically not being paid attention to by the best and brightest scientists around the world. Sure, we've got a few great people working on them, but we don't have the focus of every great scientist out there on global health problems. So he looked back. He's a very avid reader, and he studies a lot about math and physics and science, and Bill Gates, that is. And he stepped back and said, maybe we could do something like was done in the mathematics field back at the turn of the last century, which was they actually found and identified the key challenges that were the bottlenecks to creating the next wave of mathematics solutions. So Hilbert was a famous name for putting these challenges out there. And it galvanized, in fact, the mathematics community into a new wave of energy around mathematics as a fundamental tool. So he said, why can't we do that for global health? And so what we did was we went out to the world, we asked them for input, and in fact we got over 1,000 responses in terms of what were the key scientific and technical bottlenecks to solving the problems, those diseases and health conditions that I laid out there before. And from that we distilled 14 grand challenges, but we really now think about them in terms of 7 broad goals. Improving childhood vaccines. So how do we actually make vaccines that can get out to these rural settings? There was a great example you spoke to about polio. It is a labor of love to get polio out there. It's not the easiest thing to get something that requires a refrigerator out to some place that doesn't have electricity. So we'd like to see vaccines that don't necessarily need a cold chain, or a better cold chain that's cheaper and more robust and out there. Creating new vaccines. We don't know how to reliably create a protective vaccine. In fact, that's why we don't have any vaccines for HIV, TB, malaria, because we can project all we want. We can do computational tools. We can do all kinds of mouse experiments. But the bottom line is when we put it in a human being, it's kind of a surprise at the end what comes out. Controlling disease-transmitting insects. Clearly, a lot of the diseases we're talking about are transmitted by insects, whether it's mosquitoes, sandflies, or others. We don't actually have effective tools. We have some tools. They've had a huge impact. We see huge impact from residual indoor spraying, also from bed nets that are insecticide-treated. But we know we need better tools, and we're seeing emergence of resistance against those products as well as we go forward, just like the drug resistance. So we need to change that dynamic. Improving nutrition to promote health. 20% of the kids in the world are undernourished. It's really staggering. And in some countries, it's more than 50% of the kids. That is a huge legacy impact. So some of those kids, in some countries as much as 50%, are literally physically and cognitively stunted and will be for the rest of their lives post-age 2. And so nutrition is a huge impact. It probably underlies in kids under 5s. There's data suggesting about 50% of the impact of the infectious diseases themselves. So there's a huge huge impact that can be made simply by improving nutrition, not just caloric intake, but really the quality of nutrition overall. Improving drug treatment of infectious diseases, it boils down to a topic mentioned earlier, which is about the emergence of resistance. If we're constantly on a treadmill, then as the next disease arises and the next problem emerges, we won't have a set of tools in our bank that are actually robust and sustainable. Curing latent and chronic infection, I spoke about TB, huge problem, 2 billion people infected with TB. Latent TB, and we have other diseases, certain forms of malaria, et cetera, where in fact people are sitting with dormant potential disease. We need to understand and know how to deal with that. Same with HIV. Measuring health status accurately and efficiently. The best way to know what the problem set is to be able to measure it. We don't actually have tools. Most of the countries that we deal with don't have robust systems for actually measuring the state of health in their populations, particularly the poorest populations. Part of that's about the technology, part of it's about the system it resides in. We need to solve some of those problems. Better technology can enable some of that. So we started with this program, Grand Challenges in Global Health. As Bob mentioned, we have done almost closer to $500 million went out originally in 45 grants that did touch about 400 investigators involved in it, a huge effort. We've made incredible progress. I can't even begin to tally up here, but everything from new approaches for handling insect transmission of disease through changes in the insects themselves, new molecular targets, new types of chemical products, to new tools for dealing with nutrition. All kinds of things have come out of there. It's a wonderful story, but I'm not going to focus on it today. I want to focus towards the future and some opportunities ahead. I would comment, since I'm up here in Vancouver today, that we had partners in that, not least of which was the Canadian Institutes of Health Research, who actually have been critical partners for us, not just in that initial round, but continue to be partners of it with us as we think forward into the grand challenges in global health, but also Wellcome Trust and the Foundation for the National Institutes of Health. I would comment that we learned a number of, and I would also comment that we had enormous Canadian contribution in that first wave of grants, not only Bob here, but also Brett Finley and Frank Plummer and Lauren Babiuk and Peter Singer, who will be here tomorrow, and Abdallah Dar and folks. So there's just a range of folks across Canada who have been huge contributors in this. So we absolutely want global involvement, even if you're next door. But as we move forward, one of the lessons we learned in Grand Challenges in Global Health, the original 45 grants, is that some of these problems actually required more innovation. And going out, you can do the math yourself here, grants that on average were about $10 million. It's hard to get people to say, yeah, I'm going to risk $10 million on a really off-the-wall idea, right? So we started a little too big. We maybe didn't get enough innovation in some of the areas where innovation was needed. And we stepped back and said, maybe we need a second flavor of Grand Challenges in Global Health and a third flavor of Grand Challenges in Global Health. We've done a lot of learning in the course, and in fact, we found some of the paths are becoming clearer, some of them becoming murkier, but some of the critical elements along that path that I talked about to impact have defined themselves. So we've begun to shape much more clear and specific solicitations for involvement. Some of you may have seen last year, I think it was December, we launched one specifically around platform diagnostics. I think you can anticipate that was going to put about $30 million against platform diagnostics over the next couple of years. And in fact, you'll see more things like that rolling out from us in partnership with the Foundation for the National Institutes of Health, deeper investments in vector-borne disease control, et cetera. Let's talk about innovation. We really do believe that additional innovation is needed. So we've created a new program called Grand Challenges in Global Health, but it's called Grand Challenges Explorations. Focuses on the same 7 goals I talked about, because really, when you get down to it, almost all the major problems that we have in getting to health solutions, new health solutions, fall into those 7 buckets. But what we wanted to do was make it easier for entry for a really off-the-wall idea, something that could be paradigm shifting. Easier entry for people who hadn't been in the field before. The problem is, if you're asking for a $10 million grant, you probably need to have had some track record in the field. We want to bring people in from different disciplines, people who have new ways of thinking about it, who may be working in cancer or maybe working on some chemical engineering problem, look at our problem and go, gosh, that looks a lot like this other thing I've been working on. I think I can make a dent in this, and actually step to the plate and do that. So when we did that, we stepped back and said, we need a new format for doing business, which is we need topics that are going to change so people have more than one chance to come in. The problem with the first round is we had one call, and everybody who didn't make it kind of was out of luck. So we accept applications twice a year. We made the burden of entry really low. 2-page proposal. Not too many of those going around. No preliminary data required, but you do need preliminary thinking, and an accelerated review process. You're going to get an answer within about 3-4 months. It's a different kind of review. We went around, talked to our colleagues who are funders. We talked to people who get grants from us, who don't get grants from us, and we said, what's the biggest challenge limiting innovation? Most of them said peer review. So we stepped back and said, how do we do peer review? I don't know how it's exactly done in Canada, but in the United States, it tends to bring it down to the most conservative view. They said, let's try something different, and that is champion-based innovation review. So it's more like venture capital, which is to say, wow, this is a great idea. I trust the person who's doing the review here is making good bets, and let's just give this thing a bit of money and test it, but let's build in a stage of investment. So that we start with something small, we mitigate our risk, we move to something bigger. As we learn more, we learn more. So that's what we did. We have a group of people who review this who are, among people who have been entrepreneurs, serial entrepreneurs, started great companies, seen innovation, people who have sat on VC boards, people who are Nobel Prize winners, people who are in, MIT innovation tech type, 35 youngest folks. So real range of people who have a serial history of innovation, and empowered them to select individual ideas, and we will fund them if we can work with the organization. The path forward, as I said, is stepped. So you come in, you can get $100,000. Very little questions asked about what you're going to do with it, other than that you have to have a great idea. You have to tell us what the impact is, and you got to tell us what you're going to do with $100,000. That's going to make a difference in the way we think about a next investment. The next phase can go up to $1 million. We've just begun to get the cycle of those coming in, and so we're beginning to see awards in that space. I think maybe about 20 have been given so far. I'll give you a couple examples in just a minute. But we're really looking for people to come in. So that launched about maybe 2 years ago. We've had 18,000 applications from 130 countries. It's really global. We get about 3,000 applications every round. So the odds are against you. I'm going to be frank with you here, okay? Good news is it's a 2-page proposal. You can put in again and again and again. You can put in lots of ideas. You and your colleagues, everybody in the whole lab can put them in. In fact, we found some universities were using it as a tool. At Caltech, there was a commitment by the university that if a young student, and you can be a graduate student, postdoc, you can be a Nobel laureate. We've had all of the above winning. They made a commitment that if graduate students and postdocs actually won one of these, that they would make a faculty mentor and lab space and resources available to do the project. In some places, it's been a bonus credit in classes for people to apply to these and see if they could get awards. We've had some great stories. There was a guy actually at Caltech who didn't get it, but the idea, somebody liked it, they wrote it up in the local paper, and a local entrepreneur funded it out of his own pocket and paid for the idea. So that was great, leveraging money. Anyway, we've had 11 topics out there so far, and there are new topics every year. There are 2 new topics every round. We usually do 4 to 6 topics at any particular solicitation time. It tends to happen around the beginning of May and then the beginning of September. So you'll see that it goes across a range of areas here, and they tend to be more kind of ranging from very specific questions like, can you induce mucosal immunity? Can you actually create new contraceptive tools that are appropriate to these resource-poor settings and the demographics, to very broad-ranging things like, can we limit drug resistance? Can we protect against infectious diseases? How do we create more effective vaccines, improving the health of mothers and newborns? What we do is we lay out a problem for you, and we tell you what we think is important about that problem, and then we tell you what we have some ideas of things that might be in the vein of what we're thinking about, but they're not the only things. We want you to come up with better ideas. And then we tell you what we're not interested in funding. What we're not interested in funding is all that stuff that normally gets funded in this space, okay? Because what we want to do is capture everything that's outside the normal paradigm, but still within the realm of possible, the things that wouldn't get funded otherwise. And so that's where we invest. And so, as I said, we've done a lot of proposals. We've funded 340 grants, 34 million so far, 31 countries. Right now, there's an open round, so I challenge you to go take a look at it and see if there's something there you're interested in. There are 4 topics out there. 2 of them were out before once, which is low-cost cell phone-based applications for priority global health diseases. So how do you couple cell phone technology to solving some of these problems? Because cell phones are the most pervasive, probably, technology on the planet at this moment. I mean, you can go to amazingly resource-poor settings and see cell phones being used. Create new technologies to improve the health of mothers and newborns. This is really about what I said before. We know what some of the problems are at that stage of delivery in the first 30 days, but we don't have the right tools to work on in those resource-poor settings. We need improvements there. Catalyzing sanitation, and then new approaches to cure HIV infection, not treat it, but cure it, like literally get rid of it, cleanse a person from it. So what's interesting about those 2 new topics is that we're doing them in partnership with others, which is the first one on water sanitation we're actually doing with our Global Development Program. So they see this as an attractive tool, and we have a huge interest in this because of enteric diseases. And then new approaches to cure HIV infections is in collaboration with the NIAID at the NIH. They actually came to us and said, you know, we have a hard time getting high-risk, innovative stuff funded. And we'd love to work with you to shape this so that these investigators can come to us when they get some traction on proof of feasibility. So we think that's a great opportunity for us to work with other funders who maybe can't work as flexibly in the innovation space as we can. That's one of our real comparative advantages. So let me just give you 2 examples of the kinds of things that have come in here. This is one of the projects that has moved from a phase 1 to a phase 2, so they've ramped up. They came in with an initial idea that there was actually a hypermutation phenotype in malaria parasites, and that one might be able to create adjuvant drugs that would actually limit that hypermutation function so that you wouldn't get the emergence of drug resistance. You could use existing drugs for longer, so extend the longevity of drug lifespan before resistance emerged. And in fact, got great data in the first $100,000 and the first year and a half, and came back to us and is now scaling to actually begin doing screening and looking for leads in this area. The second project, this is an example of somebody coming from a completely different field. Marcus Schabalek's, Columbia, actually is in astrophysics and works on things related to light, etc. I don't actually know what the primary projects are in that lab. Came to us and said, you know, it's interesting. It appears as if insects actually are very sensitive to the light spectrum that they're experiencing. And in fact, it looks like mosquitoes, we have a hypothesis that mosquitoes are going to be limited by some kind of light. And so we've got a problem with bed nets, which is bed nets are great when they're used, but a lot of times you go visit people and they say, yeah, I got my bed net, and then they go under the bed and you find it in a plastic bag that's never been opened because they live somewhere where it's 110 degrees at night and the bed net makes it hot and they really just don't want to use it. You know, or the case that we have emergence of resistance with the pyrethroids that we're currently using, and so, in fact, it's a limited lifespan before those drugs expire. So can mosquitoes actually be limited by that? Well, in the first $100,000 we gave these folks, they actually came back with data that seemed to suggest, yeah, there was a certain set of frequencies where, you know, basically those mosquitoes weren't going through. And so the question now is to really scale the testing of that hypothesis. It's easy to build something cheap that could be kind of the equivalent of a virtual bed net with light, or a virtual house net with light, or block your windows with screens of light that would help protect against the insects coming in. So you can conceptually think about it. It sounds kind of cool. With cheap lights like you have in your scanners at the supermarket or whatever, or in your remote control at your TV. And so this is something we're investing deeper in. So crazy ideas like this, microwaves to cure people of malaria, changes in how you cure TB by seeking it in and clipping it back out again. So we've got some crazy ideas out there. So I'd encourage you to take a look at it. It might stimulate your own thinking about some crazy ideas. But we basically are trying to solicit people to think about these things in new ways, new paradigm-shifting ways, and we're willing to put some money against it. I actually have some cards down here that give you the website and whatever. If nothing else, I tell people it's a great short story read to actually go to this website and read the hundreds of projects we put in place. It's a lot of fun there. I'll tell you, I think it's a lot of fun, but it's worth taking a look at. So I just want to leave you with a couple of thoughts here. One is that there are lots of ways to contribute to solving the global health problems. You heard there's a lot of diseases, a lot of problems. We need vaccines, we need drugs, we need new prevention tools, we need better diagnostics that work in resource-poor settings. We need them created in a way where they will be available, reliable, sustainable, and cheap, right? So that takes a lot of innovation, not just innovation on the science and technology side, but also on the business model side and the delivery side. I encourage you here to take your talents against those problems, but science and technology can make a difference. We see that what vaccines has brought to the world in terms of transforming the way we do things, antibiotics, new drugs, transform our ability to actually make a dent in the world's health issues. And so I would encourage you to think about science and technology as a great way of leapfrogging over problems that have been hard to solve, which sometimes are things that are more infrastructural. So how can you work with us? People are usually interested in that, particularly in the university setting, which is twice a year we do solicit applications through Grand Challenges Explorations Initiative. There's a website up there, and I got some cards down here if people want them. And then we also do, for the rest of our strategies and our work, Grand Challenges Explorations is a very small window relative to all the work we do. But it's a window that's really open to everybody on a very level playing field, and I would encourage you to take advantage of a way of getting to know us and to work with us and us getting to know you. But for all the other work we do, we actually do post on our website our strategies so you can read about what we're interested in. I strongly advise, if you're thinking of approaching us about something you want to do, that you read the strategies first, because if they're not in our strategies, we're unlikely to fund it. We have an open invitation on our website for people to submit ideas. Obviously, we get a lot of them, so once again, think wisely before you send something about really thinking about what it is we're looking for. And then we do issue requests for proposals. I think that's an increasing method we're going to be using, so you'll see those posted on our regular Gates Foundation website, and if they're with Grand Challenges and Discovery, they'll also be on the Grand Challenges website. So I'd encourage you to take a look at that. So I just want to leave you with this quote from Bill Gates, which I just continue to find compelling, even though it's 5 years old, which is really about the importance of science and technology, but it's not just about science and technology. So, there really is no bigger test for humanity than the crisis of global health. The fact that so many can be affected and that much of the world sits not even knowing that it's happening is really a tragedy. And so, as he says here, solving it will require full commitment of our hearts and minds, and that's clearly the case. But we need science and technology too, because without science we can't do anything. So without the tools to make the difference, tools that actually can work in those settings, we really won't change the face of global health. And so I encourage you to all join us, and those of you who already are working on these problem sets, hope we get to know you better or continue to have the opportunity to work with you. And I want to thank you all for your attention.
I'm sure Carol will be delighted to have some questions. Well, I'm going to just start off.
Okay.
So it seems to me you're involved, in a sense, in a pyramid scheme. You started from a central focus,
Explain.
and then you're expanding. And I think we've seen the expansion of the foundation from a relatively small organisation to a multi-billion-dollar organisation. So I'm wondering if it doesn't keep you awake at night worrying about what's going to happen as you keep growing all this massive portfolio of things. I think you've got a lot of things in the clinic, you've got a lot of things in the field. How are you going to manage this?
It's a great question. So I'm going to answer it sort of on two fronts. One is the U.S. economy actually probably took care of that log growth. So we're pretty stable right now. So that's my first answer. But the second one is actually true. It does keep us awake at nights. And actually, if you read Bill Gates' letters and our annual reports and so on, you'll see that it does keep us awake at night because what we've done is we've ourselves contributed to accelerating, the field. But actually, while we've been doing it, the whole world's been accelerating. There are just a ton of opportunities out there. And the problem is that for each one of those great ideas that moves forward to a clinical trial, the cost of the clinical trials increase and expand. And then the issue of actually getting out and delivering it expands as well. I mean, the challenge of finishing off polio remains a surprising funding challenge, even though there seems to be a good plan to getting to that. So that's where the other kinds of work we do is really important, which is we really do work with partners. We can't do this alone, and we really need to be involved with other world-based organizations, whether it's countries or the Gavis and the global funds of the world, the polio campaign, the President's initiative around malaria, et cetera. We really do need to work with other partners. We see increasingly that other funders, so research funders, seem interested in global health. We try to work to align so that we don't overlap in what we do, but we actually synergize in what we do. But I think there is a lot you have to be done, so we also do advocate, and we work to support our partners in advocating to get the attention, to get the policy changes, and to also get more resources against the problem. Yeah, I don't know that I have a good answer, but that's what we're trying to work on.
That's a good answer. Up the back there.
Tony Roach from Duke. Question, do you see the Gates Foundation being involved in the development of surgical programs or surgical program expansion, specifically thinking of issues like trauma, relating to construction, motor vehicle accidents, and all the rest of the developing world, and then B, also with the delivery of maternal health, also the surgical issues that are associated with that, being safe, cesarean sections, providing anesthesia care, that sort of thing. Where do you see the Gates Foundation in that?
Yeah, so maybe two different answers for the two different topics you did. So as I said, we focus on those two broad areas. We've made a decision, even though that we know that only contributes to about 40% of the, if you look at disability-adjusted life years. For us, using the filter of inequity, we feel that the most glaring inequity in terms of attention paid is around the maternal health, maternal child health, and then the infectious diseases. So we don't work on trauma. We actually do feel that there are others who should be involved with, putting in place the policies and so on that would prevent some of that, as well as innovations coming through other mechanisms. We simply can't work on everything, although that's a worthwhile goal. In terms of maternal and neonatal, we actually are very interested in solving all the issues around birth and the first 30 days and then beyond, to 5 years and so on. And so what we focus primarily on are the poorest populations, and in the poorest populations, literally just investing to help stimulate new approaches to ensuring they get to facility-based delivery is huge, right? And so having someone who's skilled in attendance at the time that they're giving birth is making a huge difference, and we've helped to invest in, but largely governments actually are taking on ownership of that. Some tremendous programs going on, you see in India and so on, where in fact the local communities themselves become engaged in the ownership of ensuring facility-based deliveries. It's really phenomenal progress. In terms of facility-based care, we probably do less in that right now than we do in trying to deal with the local care, because the inequity is so great in the local settings. But we are very interested also in some of the facility-based issue, maybe less around surgical things, but more around intubation and how you get access to oxygen and so on out in some of the remote areas. So there are a series of things. I'd urge you to take a look at the topic around maternal neonatal and also our maternal neonatal strategies. So, yeah.
Thank you for your speech. I was just wondering, in terms of the global health challenges / exploration, that project, of the fundings that have already been granted, what, in terms of, in context of neglected diseases, what kind of funding has gone through for what kind of programs that you know of, any specific cases?
Yeah, so actually in that program we have had a number of projects that have been funded on neglected diseases. Most of them have come in through the prevent other infections, or some of them have come in through, vaccines or drug emergence of resistance and so on. Yeah, we've had some very interesting projects come in through that. I mean, there's, for instance, a project that has to do with trypanosomiasis and whether or not by altering the mobility, actually, literally, of the trypanosome when it's in the body, can you change the ability to actually effectively treat it with drugs? So it sounds crazy, but there's some traction on the idea. So we've got some interesting things coming through in that area as well. I would say our neglected diseases portfolio is less robust than our portfolio on those individual diseases than our portfolio in, say, TB or malaria or those with a higher burden. But with that said, we probably contribute more to, we're among the major funders for neglected diseases in spite of that statement. So,
and I think it's worth saying that all of these diseases are essentially neglected because they're affecting poorer populations.
That's right.
You can't deliver it to up the back there.
Yeah, I noticed that in the world map, when you were talking about the grand challenges, most of the dots are distributed into the developing world. The developed world. I assume those are like research groups that are working on different projects with you guys, right?
Yeah, so in Grand Challenges in Global Health, those big grants I talked about, most of the primary investigators were in Europe and the U.S. and Canada. Actually, Canada had kind of a disproportionate number of them. It's true. So did Australia. It's really interesting. If you look at, we have statistics we've pulled out from somebody else's study about the distribution of investigators across the world and where they are and so on. And we do see disproportionate pockets here and there. One of the challenges I think there was we had tons of developing world investigators involved. They found it very hard to write a grant of that magnitude and complexity and get it funded through that program. We had one Africa-based project, but there were lots of investigators involved, but they tended to be co-investigators. We've tried to change that dynamic in explorations. We've done heavy marketing across the world. We now see about 11 to 13% of them primary investigators being in developing countries. So we're pulling them in, but we also see that there is a challenge in terms of they're disadvantaged in terms of access to information, partnerships, collaborations, all kinds of things. And so you may hear a little more from Peter Singer tomorrow about Grand Challenges Canada, and we have a partnership with Grand Challenges Canada to help us in some of those aspects. So it's a real...
Yeah, my question was directed into if there is a way that, the Gates Foundation is actually promoting or enhancing science education and basically research capacities in the developing world, so they can actually start working for their own problems and their own.
So we don't do a lot of what I would call infrastructural work or capacity building for the sake of capacity building. That's not our mandate, not our role. There are others who do that, Fogarty, Wellcome Trust, all kinds of people. But we do a lot of it in the context of the projects we do. So we are supporting investigators, young investigators. We view Grand Challenges explorations as a huge opportunity for people globally to get in the door with us and begin to have a relationship. So, yeah.
Can I just further comment on that question? Yeah. Being DNDi sitting in Geneva, if you look at the map, you could say that basically DNDi being in Geneva, developed work, is getting money from the Gates Foundation. If you look at the project on VL, I would say that 90% of the money we get from the Gates Foundation goes to India, where basically we have our working partners. So it really also depends on how you look at the situation.
Yeah.
But again, most of the money is definitely spent in endemic countries, at least for this project, and I'm sure that other grantees basically are following exactly the same task.
I would agree with that statement 100%. But I would comment that we are very concerned about also making sure that developing world investigators begin to get their fair recognition as the primary investigator, too.
Well, I think, this you sort of partly answered my question. You talked about, this is not in your portfolio, but you were talking about that the foundation has a mandate for education in the United States. What about education in the developing world? And I did notice on your map, it's great that you're in Beijing and it's great that you're in New Delhi, but I noticed that you're not in South America or in Africa. So maybe you could speak to those 2 points.
Yeah, so the first one being around education in the developing world. It's simply sort of a matter of prioritization with limited resources. I mean, we do get involved in education in the sense of health education that relates specifically to the implementation of new things, but we don't actually fund schools and so on. We have a very small program that is actually facilitating in one way, which is out of our Global Development Group. I told you that one of the first programs we had at the foundation was digital information access in the U.S. through public library systems. We actually have a global libraries project where we don't literally invest in that, but countries came to us saying, how can we do similar things in our country? And so, in fact, we are working with developing countries who are interested in enhancing access to digital information in their infrastructure and helping to do that, but we don't generally work on education.
Second question was?
The second question was your lack of presence in terms of places in South America and Africa.
Well, so let me flip it around and put it the different way, which was I came to the foundation almost exactly 7 years ago. At that time, we were going to be about, no more than 100 people in Seattle, period, right? And now we find ourselves 780 people scattered around the world. We will never be the providers of service on the ground, and so we won't be, WHO or TDR or UNICEF or CDC having people in every country. We are trying to make sure we have sufficient access globally, but it tends to be the need for the access directly tends to be different in different settings. So right now, are we going to have a location in Africa? Not clear. Can we access better because we have a location in Europe? Yeah. We're trying to think that through. We will never grow to be everywhere.
Sure.
Yeah.
Hi. This morning in one talk we heard about the development of new assays to perform high-throughput screening of chemical libraries for different diseases. Where is the position of the Gates Foundation for those type of experiments?
Yeah, so we fund them when they're specifically in the context of a project that we want to, we're promoting actually a particular project, not a particular disease. So sometimes it's through our partners like DNDi or others who actually have those kinds of capacities, or where we may be in partnership with companies that have those capacities. We have resisted the temptation to set up a lot of proliferating high-throughput screening centers around. What we are concerned about is people having access to capacity that is highest quality to do those sorts of things. So are we interested in new drug candidates and new leads? Absolutely. In a variety of areas we are. How do you bring the best consortium of people together with the best capacities to do that? I think is going to vary by question. So it's all about the end product for us. If it's essential to get to the end product, then we might be interested in it.
I think you said this morning, Danny. Do you want to comment further on that?
Well, but obviously, as it has just been said, it's part of a development process, and obviously for which it was a missing tool. That's why basically we partner with ICK in that specific instance to develop the tool. But it's just a tool as part of a process. We never basically requested a specific funding for that part of the development process.
Yeah. And we don't tend to fund, innovations in high-throughput screening as fundamental technology unless it's something unique to the problem set that we're trying to take on. So not the fundamental technology unless it's unique. Yeah.
You can use the high-throughput screening to find specific inhibitors for a particular way to inhibit the cell growth.
Absolutely. So we do have projects that actually fund, screening and lead generation, targets, leads, candidates. Yeah.
Yes. So just on that point, so we have here, based out of the BGC, an organization called the Center for Drug Research and Development, where we do exactly that and other aspects of drug development, helping discoveries, get through the drug development process to proof of concept. So, and we're just at the moment in discussions and negotiations with NGDI to do exactly that for neglected diseases.
Mm-hmm. Great, terrific.
You.
This might be well explained on your website, and so, sorry to ask you to elaborate, but I'm not sure I understand very well the relationship between the 7 approaches and the competition. For example, one of the 7 goals was to improve health status, the measurement of health status, So I understand that to mean that that's with respect only to those specific exploration topics that were listed, or in general?
In general, we view that as a technological challenge, actually, how, in fact, in many of the developing countries, you can actually measure health at two different levels, right? One is at the individual level in a diagnostic setting, right? So we do actually have initiatives out there on point-of-care diagnostics for use in the most resource-poor settings. But then the other is we are actually invested in health information generally. And so you will occasionally see things come out that address that topic.
Does the explorations initiative include that? Or
well, so one of the examples is cell phone-based technologies, right?
Very specific, yeah.
Yeah, so the explorations can range from huge to very specific. They vary depending on what we see the problem set as being.
Yeah.
Okay, I'm going to do one last question, so I'm going to do this video.
Thanks for your talk. I'm with the Canadian Health Services Research Foundation, and we're also interested in, final health outcomes, impacts being around uptake or use. And I was wondering if you could just expand a bit more upon kind of your approach to measurement and how you go about the process of collecting your data or how you inform that uptake.
Yeah, so that's a great question. So a couple of answers, and I don't think we by any means optimized where we want to be. Actually, it's funny because measurement and impact is a constant question for us at the foundation. How do we do it better? How do we learn better? Et cetera. So on the side of kind of the last question as well, part of the problem is the data from which we're drawing is not great. So we have had investments to help countries, actually help improve. We have a couple of investments, Health Metrics Network. We also fund the Institute for Health Metrics and Evaluation at the University of Washington, which is sort of an objective entity looking at the status of health across the world and doing reports on current state of health as a way of us beginning to get baselines. But for all the projects we do that are large type interventions and so on, we do try to make sure that they all have measurement and evaluation plans that actually that are appropriately scaled. Because you can also go to the other extreme, which is it becomes the tail wagging the dog. But to get appropriately sized measurement and evaluation plans for each of the projects, and for projects that are less about that in a quantitative population sense, we try to make sure that we have intermediate measures of success along the way. So even for fundamental research projects, if you work with us, you'll find that we ask for milestones and deliverables along the way as surrogates of getting to a step in a critical path that will ultimately lead you to those population-based number differences that we'd like to see in the end. But it is, I think, a global challenge in the sense that the data from which we're drawing is poor. That is not a sole mandate for the Gates Foundation. We can try to help with it, but there's others who need to take action on that as well.
Okay, so thank you so much, Carol. Obviously, you incited a lot of interest here. And I'd like to thank you for coming, and here's a very small token of our gratitude. Thanks very much.